Good morning from winter in Colorado. I've chosen behind me a warmer scene from a trip to Vietnam a couple of years ago, which is quite a bit prettier than things are outside here at the moment. I want to thank the organizers for asking me to speak with you. I wish I could do this in person, but these are the challenges that we are getting used to these days. We're going to spend some time talking about youth onset type 2 diabetes. And let me start with my disclosures, which you can see here. In order to speak about type 2 diabetes, we need to have a good understanding of the underlying pathophysiology. And this really can be shown in this figure here, which many of you may be familiar with. What we see in this figure is the relationship between insulin sensitivity on the x-axis and insulin secretion on the y-axis in healthy adult men and women. These are individuals with normal blood sugar. And what this figure shows us is that individuals can have insulin sensitivity anywhere along the spectrum from highly sensitive to very resistant, and maintain a normal blood sugar as long as the relationship between insulin secretion and insulin sensitivity is maintained, so that as insulin sensitivity decreases, insulin secretion rises. Again, as long as that relationship is maintained, blood sugar remains normal. The important point here is that in reality, type 2 diabetes, much like type 1 diabetes, but for different pathophysiologic reasons, is a beta cell disorder. Again, you can maintain normal glucose tolerance anywhere along the spectrum of sensitivity, as long as beta cell function is appropriate for that degree of sensitivity. However, as beta cell function starts to decrease, one initially develops rising blood sugar, maintaining within the normal range at the beginning. But then as beta cell function begins to decrease further, one develops impaired glucose tolerance, impaired fasting glucose, and eventually type 2 diabetes. So again, it's important to keep in mind that type 2 diabetes is at root a beta cell dysfunction that prevents appropriate compensation for the degree of insulin sensitivity. If we look at insulin sensitivity across the spectrum of dysglycemia in children, one sees that as individuals go from normal glucose tolerance to impaired glucose tolerance, insulin sensitivity is more or less unchanged. However, as these individuals progress to type 2 diabetes, insulin sensitivity falls. However, if one looks at insulin secretion, comparing those with normal glucose tolerance, impaired glucose tolerance, and type 2 diabetes, we see that as individuals go from normal glucose tolerance to impaired glucose tolerance, there's a substantial loss of first phase insulin secretion, as seen in this initial spike in insulin secretion. Second phase insulin secretion is more or less maintained in these individuals so that they have an increase in insulin secretion following that first secretion that's parallel to that in normal glucose tolerance. And then when type 2 diabetes occurs, there is also loss of that second phase of insulin secretion. Again, what matters is the relationship between insulin secretion relative to the degree of insulin sensitivity. And that can be thought of mathematically as something called the disposition index. It's essentially a way of presenting insulin secretion corrected for the demand, if you will, or the degree of insulin resistance. And what we see if we look at that disposition index, which essentially reflects this set of arrows here of following beta cell function, is that as individuals progress from normal glucose tolerance to impaired glucose tolerance to type 2 diabetes, there is a steady, substantial and consistent decrease in the disposition index. So it's this disposition index that is reflecting the true underlying pathophysiology here, the inability to make enough insulin to compensate for the degree of insulin secretion, excuse me, of insulin sensitivity. The underlying physiology here is the same in adults as in kids. You see the exact same thing. So therefore, the underlying physiology here is not different between adults and children with type 2 diabetes. However, what I'd like to do is spend some time thinking about those aspects of type 2 diabetes that are, in fact, unique to youth. Now, by necessity, most of the data I'm going to show you are based on youth in the United States. Because that is where most of this research has been undertaken. And there may be regional and ethnic differences in some of these details. However, in the United States, if we compare adults to youth, the first thing we find is that in adults, type 2 diabetes is a very, very prevalent disorder. Occurring in about 2 million new patients a year in the adult population, whereas in youth, despite what many people have called an epidemic and what is truly a drastic increase in the amount of type 2 diabetes, this remains a somewhat rare disorder with an estimate of about 5,000 new cases of type 2 diabetes in the US per year, with a total US population of between 250 and 300 million people. So overall prevalence is substantially lower, 12.3 per 100 in adults compared to 0.5 per 1,000, with an estimate of about 1 in 350 to 400 obese adolescents. Another thing that we find is that the gender distribution is quite different. In adults, it's just about 1-to-1 between males and females, where in youth and adolescents with type 2 diabetes is about 2/3 female in the United States and most other countries, although there's been some differences in China, Hong Kong, Taiwan, presented, which maybe represents some differences in biology. Overall, whereas there are 25 million patients, individuals in the adults with type 2 diabetes in the United States, the estimate is that there's somewhere between 30,000 and 45,000 individuals under the age of 18. So this remains a rare disorder. It's quite different than in adults. Secondly, what we see is in studies that have screened for type 2 diabetes in youth, undiagnosed diabetes is quite rare, whereas about 50% of cases of adult onset type 2 diabetes are estimated to be undiagnosed in the United States and identified by screening. This is not the case in youth. This is a study that looked at schools identified to be at very high risk for type 2 diabetes because they are poor and heavily minority, which is the high-risk groups in the United States. These individuals had screening for type 2 diabetes in the 6th grade and in the 8th grade. And what we see is that based on fasting glucose, there is almost no undiagnosed diabetes in these kids, even though they are at very high risk. The same was true for 2-hour glucose, although a substantial amount of impaired glucose tolerance was identified in this study. Another thing that we see is that there's a tight relationship between type 2 diabetes and puberty. So this is a study called SEARCH that is a population-based study of childhood diabetes in the United States. And what we see is that before age 10, almost all the diabetes is type 1 here in yellow, with a very small amount of type 2 diabetes in the orange, among those the most high risk, that is African Americans, Hispanics, and Native American Indians. However, when puberty occurs, all of a sudden there's a dramatic shift, so that now overall type 2 diabetes suddenly reflects about 15% of all new cases, and is 50% among African Americans and Latinos, and up to 90% of all new cases of adolescent diabetes among American Indians. Now, obviously, there's nothing magic about age 10, so clearly this is a surrogate for the onset of puberty. So there is a very tight relationship between onset of type 2 diabetes and puberty in both boys and girls. Another thing that we see in type 2 diabetes in youth that is unique and really not generally reported among adults is that there is a fair amount of spontaneous return to normal among individuals with dysglycemia. So this is one study from Yale. I like it because it started with 100 patients, so the percentages are easy. I'm not much of a mathematician. So they started with 102 obese adolescents, and among those, 30% had impaired glucose tolerance, and that's quite a common number to see. About 30% of obese adolescents end up having impaired glucose tolerance at some point during puberty. They then followed those individuals for about 2 years with no intervention. And what they found was that about 30% of them progressed to type 2 diabetes, but interestingly, about 30% returned to normal despite no intervention. That's really something that's not seen among adults with risk factors without any intervention. Furthermore, some other studies have suggested that this rate is as high as 60%, raising questions about what impaired glucose tolerance or prediabetes really means in the adolescent population. Now, why do we see this tight relationship between puberty, and why do we see this spontaneous regression? Well, the most likely cause is the relationship between puberty and insulin sensitivity. So what we see in this study here, this is a measure of insulin sensitivity on the right y-axis. And what we see in both boys and girls is that as they progress from Tanner 1 to Tanner 4, there is increasing insulin resistance or decreasing insulin sensitivity over time. And that would cause a child who is compensated on that curve we talked about before, who suddenly has an increase in insulin resistance and isn't able to compensate any further, to decompensate and develop dysglycemia, potentially even type 2 diabetes. However, as puberty wanes and patients transition into adulthood, insulin sensitivity improves again. And conceivably, if beta cell function hasn't deteriorated too far, that could put the individual back on that curve with a return to normal glucose tolerance. That is thought to be both the cause of the relationship between between type 2 diabetes and puberty, as well as the explanation for why there is recovery in many of these individuals as they transition out of puberty. Now, I'd like to turn to the Today study, and I imagine that many of you are used to this, are used to seeing data from the Today study, the really landmark study of treatment of type 2 diabetes in kids. This is the primary outcome, comparing the impact of metformin versus the addition of metformin plus lifestyle intervention in green, and metformin plus the addition of rosiglitazone in red. And what we see overall is that rosiglitazone did reduce loss of glycemic control by about 23% by the end of the study, suggesting that addition of therapy to metformin may be useful. Lifestyle was intermediate, but never statistically better than metformin alone. So you've seen this before, but what I would like to spend a couple of moments thinking about is just the metformin alone. And what we see is that by 12 months, 75% of the kids on metformin had lost glycemic control in this study. And that 50% had lost glycemic control by 3 years. Now, what happens in adults if we compare this directly? So this next slide shows a comparison of the outcome of today to an outcome of a very similar study called ADOPT. And what we see, again, is that at 3 years, 50% of youth had lost glycemic control. And if we look at that same time point in adults, it's about 10%. So there's a much more rapid loss of glycemic control in youth than there is in adults. We don't have time to go through it, but you'll have to take my word for it. This does not reflect poor adherence. These kids were taking their pills as well as the adults. This truly seems to reflect underlying biology, and I'll show you more that defends that position in a few minutes. If we look overall at a number of studies, now comparing youth in today, as well as adults in ADOPT, adults in a US Department of Defense study, and in the UK PDS from a couple of decades ago, what we see is that the metformin failure rate in youth is about 3 times higher than that in ADOPT. The metformin plus rosiglitazone failure rate is about 2 to 3 times higher in youth than in adults. And interestingly, however, this is not due to a rapid change in insulin sensitivity. In fact, the adults were changing insulin sensitivity or developing insulin resistance at a much higher rate than youth in ADOPT compared to today. However, what we see is a much greater loss of beta cell function over time in the youth in today compared to any of these adult studies. So there appears to be a very rapid loss of beta cell function, accounting likely for this loss of glycemic control, since we already discussed the importance of beta cell function on glycemia. I would like to tell you about another study called RISE. RISE was looking at the ability to intervene in patients with type 2 diabetes. But the important thing for our discussion at the moment is that this was a head-to-head comparison between adults and youth with the exact same inclusion criteria and same testing protocols in both the youth and adults, except obviously for their age. So this is the first time we've actually had head-to-head comparison using the exact same protocols between youth and adults. And what we see is that insulin sensitivity in the youth is substantially lower. It's about 30% that seen in the adults with similar degrees of adiposity. And in fact, if we look at insulin sensitivity across the spectrum of adiposity, what we see is that as body mass index increases, there is a decrease in insulin sensitivity. But at any body mass index, insulin sensitivity in the youth is substantially lower than that in the adults. So even for the same degree of obesity, insulin sensitivity is worse in the kids than in the adults. Now, is this due to other hormonal effects? Quite possibly. Is it due to differences in body composition? Quite possibly. We don't know the answer to this. If we now look at insulin secretion, what we see, these are 3 different measures of insulin secretion that came from a hyperglycemic clamp protocol. Again, same in the kids and the adults. What we see is that insulin secretion is substantially higher in the kids than in the adults using any measure of steady state or maximum stimulated insulin secretion. Now, you could say, well, of course, because you just told me that the insulin sensitivity is less, and we know that that insulin secretion will increase in response to decreasing insulin sensitivity, if possible. However, if we look at this graph showing insulin secretion, this is one of the measures of insulin secretion from RISE, across the entire spectrum of insulin sensitivity, either here in raw data or log transformed, insulin secretion by the youth is higher at any degree of insulin sensitivity. So this is not simply a response to the lower insulin sensitivity in the youth. Even at the same insulin sensitivity, youth are secreting more insulin than in adults. Now, the next thing that RISE did was to look at the ability to intervene. The comparison was being made between insulin for 3 months to aggressively normalize fasting glucose to a fasting glucose of 85 milligrams per deciliter, followed by 9 months of metformin. And the idea being to remove the demand on the beta cell to see if it's possible to get the beta cell to recover. And that was compared to 12 months of metformin alone. Now, in this cartoon, I need to orient you to the next couple of slides because this is a bit confusing. But again, we have to think about beta cell response relative to insulin sensitivity. And again, this is that line showing insulin sensitivity and beta cell response related to each other. And this dot here is a cartoon representing the baseline population point. This is the point at which the mean insulin sensitivity and the mean beta cell response sits. Now, in response to intervention, there are two possibilities. There could be improvement in insulin sensitivity, improvement in beta cell response, or a combination of the two. Any of those would lead to a movement of that dot above the line. Conversely, worsening of beta cell response, insulin sensitivity, or a combination will lead to movement of that dot below the line. So what did we see in RISE? This is now looking at the baseline point here, that's that yellow dot. Then looking at glargine followed by metformin or metformin alone for 12 months, following which the treatment was removed, and we looked again at 15 months to see if there was any persistent effect. And what we see in these individuals with glargine followed by metformin is that at 12 months, there is no real improvement, but perhaps maintenance of their position on that beta cell function relative to insulin sensitivity. At 15 months, again, some improvement in insulin sensitivity, but more or less staying on that line. In the glargine, in the metformin alone, there is improvement in insulin sensitivity over 12 months, followed by a regression to the line after. Now, what happened in youth? What we see in the youth, contrary to that seen in the adults, is that both treatment arms resulted in a decrease below the line at 12 months and at 15 months. So that whereas treatment intervention had little to no effect, maybe some positive effect in the adults during treatment that then disappeared when it was removed, even during treatment, beta cell function relative to insulin sensitivity worsened in the youth. So, summarizing what we've talked about so far, what we've seen is that youth have more severe insulin resistance than equally obese adults. That compared to adults, beta cells in youth are hyperresponsive. Beta cell dysfunction in youth, unlike in adults, is unresponsive to metformin or glargine. Something we didn't quite talk about, but does come from today and the today papers that are in the literature, is that while 90% of youth will attain initial glycemic control with metformin alone, 50% will not have a sustained response. And I showed you that primary outcome data. We haven't talked about this, But we have reported that a hemoglobin A1C greater than 6.3% after initial metformin treatment predicts failure of metformin monotherapy. And we haven't yet reported this, but I'm telling you now that a hemoglobin A1C rising by more than 0.5% over any time period, even within the non-diabetic range, predicts loss of glycemic control. This poor outcome in youth may be related to higher beta cell secretory burden. In other words, the beta cells are over-secreting and at risk for apoptosis. And we've also reported that diabetes-related complications and adverse CV risk factors are prevalent and increase rapidly in this population. So therefore, these findings would argue that treatment of youth requires more aggressive efforts to improve insulin resistance and arrest the progressive loss of beta cell function than in adults, even though they're young. So how should we treat type 2 diabetes in adolescents? Well, keep in mind that metformin was effective in attaining glycemic control in 90% of participants entering today's screening, irrespective of what they were on when they entered the today's study. So they could be taken off insulin quite easily over a period of a few weeks with maintenance of good glycemic control, and actually had a mean A1C of 6% when they entered today. In addition, metformin was effective in maintaining durable control in about 50% of the participants in today. So even though the maintenance of control in today was less than in adults, it still works in about 50% of these patients for quite a long time. It has numerous benefits, is inexpensive, and is generally well tolerated if started appropriately. And therefore, metformin remains an excellent choice for initial therapy in type 2 diabetes. If insulin is required, it can generally be discontinued within a few weeks as metformin is titrated. So here's what we do in Denver, and this is reflected more or less in the ADA guidelines on evaluation and management of type 2 that came out in 2018. So we start metformin monotherapy, that is assuming that the patient is metabolically stable. Obviously, in those patients who are metabolically unstable, a period of insulin may be necessary to get them back to stability. But again, in most circumstances, that can be weaned off very quickly. We start initial metformin monotherapy, and we treat for 3 to 5 months. If the A1C is less than 6.5% at that time, we continue that therapy. If the A1C is between 6.5 and 7%, we make sure that they're taking their metformin appropriately. We optimize it, make sure that they're on as much metformin as they can tolerate. And we start to talk to the family about adding a second agent. If their A1C is between 7 and 9%, again, maximize the metformin. And we are strongly considering, in general, in our situation, adding a second agent at that point. And if the A1C at that point is greater than 9%, we're most likely going to initiate long-acting insulin, as well as potentially a second-tier agent. So what should those agents be? Thiazolidinediones, DPP-4 inhibitors, GLP-1 agonists, and SGLT2 inhibitors all have their place in management of these patients. Now we'll go through these briefly. One thing I do want to say is many people just say, well, just start them on insulin at that point. But the fact is that at least in the United States and the data from today, this isn't so simple. In today, kids who lost glycemic control were in fact started on insulin by protocol. And what we found was that in fact, at failure, at the time that insulin was started, A1C was 9.7%. And despite aggressive titration of insulin dosing, a year later, their A1C was mostly unchanged. So therefore, starting insulin following failure of oral therapy, even including lifestyle, does not correct glycemic or non-glycemic abnormalities such as LDL, et cetera, in this population, suggesting that there are barriers to successful insulin therapy in this demographic that remain to be understood. So the best approach to add-on therapy is not quite so simple. Thiazolidinediones are oral, they're once daily. They, in adults, lower the A1C by about 0.8 to 1%. They're known to decrease inflammation, promote healthy fat storage, improve peripheral and hepatic insulin sensitivity. Oh, excuse me. And they, they reduce loss of glycemic control by 23% in today. Interestingly, the benefit was mostly driven by benefit to girls. The side effects include weight gain, which appears to be mostly subcutaneous. There can be some fluid retention that's worse with insulin and in patients with pre-existing cardiovascular disease, which is not usually the case in kids, which may make kids the perfect patients for thiazolidinediones. It's been associated with decreased bone density and increased fracture risk in older patients, and we did see decreased bone mineral density in today, but not to a clinically significant extent. It's been associated with macular edema, but this was not seen in today, and there have been concerns raised about possible bladder cancer. There's no evidence for cardiovascular risk reduction, unfortunately, with thiazolidinediones. Rosiglitazone was initially associated with cardiovascular mortality in a meta-analysis, but this was not confirmed in subsequent analyses, and all restrictions have been lifted. There were no significant differences in echocardiogram findings in today on those patients on rosiglitazone. The GLP-1 agonists are agonists of glucagon-like peptide 1. They are mostly injected, but there is now one oral agent available. They promote insulin secretion, they suppress glucagon, slow gastric emptying, and reduce appetite. The agents are given anywhere from twice daily to once weekly. They lower A1C by about 1%. They're associated with weight reduction with or without diabetes, and high-dose liraglutide has been approved for weight loss in adults in the United States. One phase 3 trial in youth has been completed and others are underway, and we'll talk about that in a moment. But most importantly, there are substantial cardiovascular effects of GLP-1 agonists. This is the LEADER trial. These are patients at high risk for cardiovascular disease who were randomized to receive placebo or liraglutide on top of whatever their existing therapy was, and the outcome was a composite outcome of cardiovascular disease or death. There were 9,000 participants in this study. What they found was by A1C, about a 0.4% difference over time in A1C, substantial body weight loss of about 10 to 15 kilos in these patients on liraglutide, but most importantly, a reduction in composite cardiovascular outcome with a hazard ratio of 0.87 over time. So a benefit in prevention of cardiovascular outcomes. There was also lower rates of nephropathy. There were no differences in pancreatitis or cancer, no differences in medullary thyroid cancer, both of which had been a concern. GI events, however, did lead to discontinuation more commonly with liraglutide. This is the study of adolescents called ELLIPSE that was in the New England Journal about a year ago. What we see is the expected decrease in hemoglobin A1C from about 7.8 to about 6.8, so a decrease of about 1%, which persisted over time. And we see at 52 weeks, a 0.5% reduction in A1C in liraglutide patients compared to a 0.8% increase in the adults, in the placebo-treated patients. BMI decreased in both groups, interestingly. That's what happens when you're in a study that includes a lifestyle intervention. But among the liraglutide patients, that weight loss continued up to 52 weeks, whereas among the placebo patients, that weight loss waned over time. So liraglutide appears to be effective in kids, and this led to FDA approval for individuals. DPP-4 inhibitors lower A1C by about 0.4 to 0.8%. They're once per day oral. They're available in combination with metformin. They are strangely weight neutral, even though they're acting by preventing the breakdown of endogenous GLP-1. There is no hypoglycemia. A phase 3 trial of sitagliptin has been completed, and results were reported at ISPAD showing no benefit when added to metformin. Trial of other agents are underway. SGLT2 inhibitors lower A1C by about 0.5 to 0.8%. They're once per day oral agents. They're also available in combination with metformin, which makes them very convenient. They're associated with substantial weight loss at times. Phase 3 trials in youth are underway for several agents. Again, SGLT2 inhibitors have long-standing benefits for cardiovascular and renal prevention. This is the CANVAS program that looked at placebo or canagliflozin added to existing therapy among 10,000 adults with A1C between 7 and 10.5%. Again, we see the lowering of hemoglobin A1C and canagliflozin from about 8.2 to 7.5 initially, with a waning of that effect, as you often see in clinical trials, with an overall mean difference of about 0.6%. There is substantial weight loss with canagliflozin relative to placebo. Again, you see some placebo weight loss as part of being in a clinical trial, but canagliflozin has a greater degree of weight loss. But most importantly, canagliflozin lowered systolic blood pressure, decreased progression to albuminuria, although there was higher LDL. If we look at death from cardiovascular causes, as well as non-fatal MI and stroke, again, we see, like with GLP-1 agonists, a decrease in cardiovascular composite outcome in patients receiving canagliflozin. There were concerns initially about increased incidence of amputation, but this has not been subsequently confirmed. There are reports of increased genitourinary infections, some increased diuresis, although my patients don't usually report this. There may be increased fracture risk. In this study, there was no increased DKA, but this remains a concern in certain circumstances. So, given that background, how do you select a second agent? A couple of pearls from experience. Do not use sulfonylureas in youth. They're associated with substantial hypoglycemia, likely related to that beta cell hyperresponsiveness that we talked about. Also, sulfonylureas are associated with rapid beta cell loss over time, and these kids are already losing beta cells rapidly, so it makes no sense to give them an agent which may be worsening this. Thiazolidinediones may be a good choice for those with severe insulin resistance or metformin intolerance. If they can't take metformin, thiazolidinediones are a good substitute. Be careful in those on insulin because of fluid retention. DPP-4 inhibitors have excellent side effect and safety profile, but their benefits are modest. And in our practice, we use them for individuals who have a rising A1C, but are still in the non-diabetic range, where we don't really need to reduce that A1C, but we want to prevent its rise. And that seems to be effective in our hands, but that's just anecdotal. GLP-1 and SGLT2 inhibitors have similar benefits in lowering glucose, promoting weight loss, and reducing long-term cardiovascular risk. There hasn't been yet a head-to-head trial to tell us which of these is the better agent. The choice between them needs to be individualized based on availability and cost, tolerance for the injections, although an oral GLP-1 is now available, and individual consideration of the different side effects that occur. In very obese patients, the polyuria may lead to problems with hygiene, increased risk for yeast infections, for example. Some of the headache and nausea that you get with the GLP-1s may be unacceptable to some patients, for example. So this needs to be individualized. And eventually, hopefully, we'll have head-to-head comparisons of these drugs to help us make these determinations. And finally, I do want to say one thing about bariatric surgery. We were able to do a head-to-head a comparison of kids in today with matched kids from a bariatric surgery trial called Teen Labs. And I just want to show you one thing. So this is A1C in the non-diabetic range, in the pre-diabetic range, and above 6.5% in today. And what we see is that over time, there's loss of glycemic control with fewer and fewer kids in the non-diabetic range and more with an A1C greater than 6.5%. Whereas in a matched group of kids having bariatric surgery, what we see is something quite different. A similar baseline with somewhat more kids in that greater than 6.5 group, but over time, nearly all patients developing a non-diabetic hemoglobin A1C. So there is likely, until we are better at medical management, a place for bariatric surgery in the management of adolescents with type 2 diabetes. And with that, I will stop, and I'm happy to answer questions. Thank you very much.